Now that we've covered what it is a clinical psychologist will do in this intake interview or in the early processes of trying to help somebody out, we're going to look at how we actually define abnormal behaviors within the field of clinical psychology nowadays. And when we talk about how we kind of define, or I guess describe would be the better word, the different types of abnormal behaviors slash abnormal ways of thinking people experience, we have to recognize that we've gone through a bit of an evolution over the last few decades. When we started trying to help people with clinical disorders, when we started to kind of form this branch that we nowadays call clinical psychology, there wasn't a lot of framework for how we would go about helping individuals. In fact, if we go back about 100 years when the first clinical psychologists started in the field, we saw a kind of messy approach to this idea of clinical psychology. There was this recognition, this understanding that a lot of clinical problems probably came from mental issues, things going on inside the head. But when clinicians tried to diagnose what these mental issues were, they were kind of on their own. So when people like Freud and Jung and other people that were clinicians during the early 1900s tried to help their clients or their patients, they just handled people on a case-by-case basis. They would see them, talk to them about what they were going through, and just kind of try to individually help each person on their own. There was no assumptions of overlaps between individuals, no assumptions that you could help large samples of people who had similar problems. It was just one person at a time. At least that was the kind of prevalent philosophy for quite some time. But as clinicians like Freud, like Jung, like many people around the years in the 30s, like Rogers and Adler, started helping clients, started to really deal with their issues, this new notion came out that each individual's problems might be their own, but there were overlaps from person to person. So when a client came to see a therapist or a clinician, if you want to call them, for a specific problem, what the therapist would often find is that that new client that they were seeing, that new person they were trying to help, had similar problems to another person they'd seen in the past, and that some of the therapeutic techniques they'd used on that other person sometimes did work on this new person. So what a lot of therapists did was they started coming up with their own definitions, their own terms for the different problems that the people they were seeing were struggling with. And each clinician had their own section of terms or their own selection of terms, their own ways of defining exactly what types of problems they would look for. And it helped them to an extent really speed things up, but there was still a major problem that people had with this. And that was the fact that there wasn't a lot of consistency from therapist to therapist. So if you, at your school, decided to go see a clinician for a few years while you were in college, and that clinician came up with a great definition of what you were struggling with, had a good plan to try to help you, you might find that you're getting better, but you didn't quite finish by the time you were finished with school. And if this was the early 1900s, what might happen after you finished with school and you moved somewhere else and went to a new school is you'd have to start all over. If you saw a new clinician, they'd have to come up with their own definitions of what you were struggling with, how they might be able to help you, because each individual's definitions were oftentimes incompatible with each other. So you'd have to start essentially from scratch, even if you were about finished with your therapeutic sessions, with your attempts to try to help yourself. So that was really burdensome to a lot of individuals. They kind of felt like they couldn't switch from doctor to doctor. Doctors couldn't communicate with each other, or therapists couldn't communicate with each other, if you want to use that term instead. And it caused a huge problem. So what the psychological community decided to do was come up with some universal standards for how we define different disorders. There's a universal one across many countries that the people in the United States do not use, but it is there. You might read about it later on. But the one we're going to talk about in this class is a standard that we use in the United States. It's called the Diagnostic and Statistical Manual of Mental Disorders, otherwise known as the DSM. And it's undergone a couple revisions, and actually in the last few years we've revised our newest edition of the DSM, and we are currently in the 5th edition of the DSM. And with each edition, the goal is the same: trying to set up standards, trying to set up some uniform ways of how we, as people in the field of clinical psychology, will discuss, will acknowledge different types of symptoms and different types of disorders that might go out there. Now, there's no idea, or at least no assumption within the DSM, that the disorders they identify are inherent. We'll talk a little bit later about how that kind of gets mixed up as we progress in the field of clinical psychology, where the disorders are kind of the causes of problems. In reality, what the DSM is just kind of set to do is come up with a way to describe some of the symptoms people are feeling. So if you see symptoms, you want to categorize them to communicate more effectively, you call those symptoms something like depression or an anxiety disorder. Now, people don't necessarily like the stigma of those labels, but originally the DSM was simply set out to allow therapists to communicate with each other more effectively. And what we're going to do now is break down what the DSM is all about. If we look at the 5th edition of the DSM, what we see is a very highly revised version of what's been going on in past editions. So in past editions, the DSM-3, I think even the DSM-2, and definitely the DSM-4, there was these things called axes. So when a person would see a clinician, what the clinician would do was look at 5 different axes of problems that somebody was struggling with, write down these things so they could kind of uniformly diagnose and communicate with others about what's going on with an individual. In this 5th edition of the DSM, we've finally done away with the axes. We often call them categories, just to make things easier and to kind of stick with the language you probably hear once you get out of here. I'm going to talk about the 3 categories / axes, hence the reason why you see axis in parentheses there, or not parentheses, sorry, in quotations there. So you can kind of understand where that term axis comes from. And the 3 categories for the new DSM are supposedly much more complete, much more broad in their definitions, so clinicians can communicate with each other more effectively in a way they couldn't in past situations or past DSM versions. In the first axis, what we see is a listing of major things that a person is probably struggling with and probably seeing the clinician for. So the first major part of the first category / axis is what we call psychological and developmental disorders. These are the things that people usually see a therapist for. So if you have depression, if you're struggling with an eating disorder, if you have some type of attention issues, or even if you have some type of developmental issue. So different types of I guess growth issues get categorized into this. These all are things that theoretically can be at least treated. So they might not be curable, not that they're really a disease, but these are things that you can kind of try to address and hopefully overcome. The other types of things that are listed in here are called personality and personality disorders and intellectual disabilities. Personality disorders are broad problems that a person's struggling with that affect them pretty much in their everyday life. Most people do not see clinicians for personality disorders, even though these things can have a huge negative impact on them. A great example of this is something that we call antisocial personality disorder. People who kind of have this disconnect from people in the environment. So they don't really see individuals as human beings. They don't feel empathy for them. They just kind of see people as objects, ways to get what they want. And that can have a huge impact on their daily activities. It can really hurt their social lives. It can cause them to get into a lot of trouble over the years. But for most of these people with this personality disorder, they don't realize that it's something that needs to be treated, which is why it's defined as a personality disorder, not a psychological disorder. Intellectual disabilities, like mental retardation, which we no longer call a mental retardation. The new PC is low adaptive functioning. So you probably want to get familiar with that term, low adaptive functioning, or having an exceptionally low IQ through some developmental or some environmental process. It can also be listed here. But the thing that usually is listed here, unless we're talking about some major physiological intellectual disability, is what we call personality disorders. The last thing that we list here, and this is something that was in a whole different category before the 5th edition of the DSM, is the person's general medical conditions. So we look at medical problems that might possibly exacerbate some of the situations that a person's dealing with. So if you've got a heart attack, or you've had some type of major strain on muscles and suddenly you're struggling with fatigue and depression and anxiety, well, those things might be something we want to address, we want to look at. But you can also look at these things that might interact with the treatments. So if you do have heart issues, you probably don't want to prescribe a drug or prescribe exercise to an individual that might exacerbate the heart issues. So it's kind of a way to not only look at what might be causing or triggering the disorders, but also to kind of look at some of the different paths that you could hypothetically pursue based on the person's medical past and possible medical future. The next two, what we call again axes or categories of the 5th edition of the DSM, involve kind of general functioning. So the second part, or the second category that we look at, is listed as psychosocial and environmental problems, which looks at kind of the environment, the social world that a person's encountering, maybe past traumas, things that can kind of be causing or really exacerbating, making the mental situation that somebody's struggling with significantly worse. So if you've had a bad breakup, you've had a death in the family, you've possibly had a parent that did something, maybe if you have an eating disorder, maybe they forced you to eat certain types of foods or were kind of very hard on you if you ate. Those are the types of things that we list here. So a clinician can again look for some of the potential causes to the disorder that you might be struggling with, and also kind of look for a better path to helping the individual out as you're trying to work on a disorder. The third axis, or the third category, is completely new. So they used to have something called the Global Assessment of Functioning, which was just a score from 1 to 100, 100 being you were actively participating in the environment, everything was going great, 1 being you were just completely incapable of functioning. Most people would fall somewhere along the middle, but many people thought that was just entirely arbitrary. So a clinician would never give somebody a high score to begin with, and then successively as they went through therapy, just keep raising that number to kind of indicate that they were helping the client, even if the person didn't feel like they were being helped. We did away with that GAF. Now with the third category, what we're listing is this new standard that kind of links the United States version with the international version of clinical diagnosis. And it's called the World Health Organization Disability Assessment Schedule. And it's somewhat like the GAF in the sense that they're looking for functioning here, but now they're looking at it across a spectrum of different things that people can be struggling with. So they're looking at cognitive ability, physical ability, how well somebody's taking care of themselves, how well they're getting along with others, what they do, how much they're involved in their environment and their community. And by listing all of these things, giving a concrete definition to what's going on in the person's life, there's an assumption that you get a much better grasp of how much this disability or these problems are really hindering the person or affecting the person's life. So it's much more time consuming to write down this information in this third category or axis. But the belief is that it gives us a lot clearer picture of what's going on with the person than we had in the last edition of the DSM, or the 4th edition of the DSM.
Now, before you get too enamored with the DSM, though, I do want you to at least take note of the fact that there are lots of people that have complained about this particular manual over the years. And usually when we're talking about complaints with the DSM, they're about very specific things. One of the problems that people often talk about with the DSM is the fact that when we're describing people as having specific disorders, oftentimes we just assume that somebody either has something or doesn't have something. We call this a dichotomous relationship. But more often than not, what most clinical psychologists believe nowadays is that people tend to often fall on what's called a continuum of sanity. So you don't have depression or you don't. You range somewhere on some level of depression. So there's no breaking point for most people to actually have a specific disorder. One of the more common statements that people make, even though it's kind of offensive, is that we're all a little crazy. Namely, each of us has different things that we're struggling with, different problems. Some of those things might make the threshold of being qualified as being a disorder in the DSM, But many clinical psychologists argue that we don't necessarily need to have that threshold met for somebody to have those things impact who they are or impact different aspects of our lives. So many people have argued that instead of having this dichotomous relationship of having something or not having it, we should be focusing more on a continuum of where people are on different disorders. Another problem that we have with the DSM is the fact that when we describe how we define somebody as having a disorder or not, or I guess when we qualify somebody having a disorder or not, a lot of the qualifications or the requirements that we have to define having a specific disorder seem extremely arbitrary at times. If we talk about depression, usually you need to display depressive symptoms for a certain number of months. In addition to that, though, you need to display a certain number of different symptoms. If you just display one or two symptoms, that might not be sufficient to actually be qualified as having full-blown depression. And this kind of arbitrary nature of looking for specific things that don't necessarily seem to overlap with each other that well, and needing these things for a certain period of time, rubs another number of people in the field of clinical psychology wrong. But to be more, I guess, consistent, to be able to define things more efficiently and effectively, it's very difficult to kind of move away from this, to come up with a better approach or a better method that could help us still maintain some standard and form of communication, while also tailoring treatments and diagnoses to the individuals that are there. In addition to those basic problems that we see with all diagnoses, there are some other things just in general about the DSM and how it's used in assessment that don't usually go over well with people. One of the classic problems that people have with this DSM is the fact that when we're talking about disorders, we have to remember that these things are not inherent. There is no, to the best of our knowledge, depression gene. In fact, there is no law about what is depression. Instead, we define depression because some people agreed upon specific symptoms and specific prevalences to be defined as depression. And what this means is that we can sometimes create disorders that seem somewhat arbitrary. A classic example of this was homosexuality. In the first DSM, this was paired with other symptoms and other types of disorders, like anxiety disorders, or anorexia, or attention deficit disorder. Or actually, at that time, it was called, what was it called? Well, it's not ADHD. It was, oh my gosh, ADD, sorry, attention deficit disorder. Homosexuality was considered no different from these things. Nowadays, it's not taken off of the DSM, but there's some residual effects and kind of residual animosity that still remains, that clinicians at the time would qualify that as an actual disorder. Another major debate that we're having within the field right now is based on the next edition of the DSM that's soon to come out. Namely, what people are upset about is this idea of defining autism and Asperger's not as separate disorders anymore, but as one thing. In the past, autism and Asperger's have been recognized as separate entities, even though the symptoms within them were the same, or similar, not necessarily the exact same, and the treatments for them were the same. And many people with autism didn't like being defined in the same category as people with Asperger's because their symptoms seemed to be much more profound. Their struggles seem to be much more severe. Both autism and Asperger's involves individuals who have kind of the inability to connect with others, the inability to understand the minds and thinking of people. But people with autism have a very profound inability to do this, and they often have heightened sensitivity to different stimuli as well. For Asperger's individuals, they didn't want to be defined as autistic because they didn't think that their symptoms were nearly as bad. And they didn't have this kind of need to have other things attended to because of how this disorder could affect them. But in the current DSM, or the one that's coming out soon, we're now trying to bond these two together. We now call it autism spectral disorder. And that kind of, again, doesn't sit well with most, but it seems to be necessary. And it's necessary for a very arbitrary reason. Namely, many insurance companies over the past couple of years have stopped allowing insurance, or I guess stopped covering medicines for individuals with Asperger's. Our argument was that Asperger's is by nature defined as fully functional or high functioning autism. And they say if people are that fully functional, even if there's a medicine that can help them, they shouldn't be required to pay for it. So the DSMs responded by just pairing those two together. Even if it might be ethical for the clinical psychologist to do this, even if it might be the right decision, it again speaks to how arbitrary it is when we talk about defining disorders. Another problem we have with the DSM is that oftentimes when describing somebody's disorders, even though we write it down in the fourth axis, clinical psychologists are encouraged not to consider situational factors when defining somebody as having a disorder or not. That means a horrible breakup, a death in the family, job instability that can all exacerbate situations are supposed to be discounted when determining whether or not somebody has something or not. Because of that, what we often see is that most people who go in to see a therapist are often described, or I guess diagnosed, with having a specific disorder. In fact, your textbook talks about the fact that nearly 50% of people going to see a clinician could possibly, because of how extra sensitive the DSM is, that statistic is way higher than we think we should see in reality. And when we're talking about the DSM, one of the last things that's really important to a lot of people is the fact that the DSM seems to only be focusing on a small aspect and challenges that person might be undergoing. More often than not, clinical psychologists need to know much more than what's contained within the DSM diagnosis. But despite these problems, I do want to reiterate that it's helped us a lot. In fact, when we talk about the DSM, what we see is that because it's been so effective, even with the problems there, the whole psychological community, at least primarily in Western cultures, have now accepted it really as the major tool to be used. In fact, in almost every reputable clinic in the States, and almost that has a firm belief in psychology and kind of the scientific applications to it, the DSM is the common tool that's used. And because it's used so often, it's very, very time efficient and effective for many individuals. Another big plus of the DSM is the fact that it is somewhat arbitrary, which seems kind of like a contradiction. If we think back to the autism Asperger's situation, we can see that even though the fact that DSM psychologists are changing definitions just to meet the times, it might be seen as a problem. It can also be seen as a benefit, a way of interacting with the critical and the current needs of a society. And this ability to constantly change disorder classifications, add things and take them out as necessary, is something that, even though kind of rubs people wrong, is seen as an asset by many people in the psychological community. And because of all these things, one other reason why you need to know a lot about the DSM is that we see no end to this particular method in sight. In fact, it continues to grow as the field of psychology expands and as the areas of clinical psychology kind of weed their way into different cultures. This marks the end of how we diagnose and really define abnormal behavior. In the next part of class, as was mentioned earlier, we're going to be talking a lot about therapy, the different techniques that are out there, and the differences between them. If you haven't read again, please do. We'll be moving on again to this final big part of what it is that clinical psychologists do. Take care, and I'll see you all soon.